This conference will now be recorded.
Hi class, welcome to your recorded online lecture. I'm hoping that you get a lot of value out of what we talk about today, and you can rewatch this as many times as you need to help you understand the information. So this is in your new textbook that you have a digital copy of. This is the new cover, Applied Anatomy and Physiology for the Manual Therapist, and we're at Chapter 7, the nervous system. Today we're covering only the nervous tissue and spinal nerves in this lecture. There is a summary video. I really love this YouTuber. His name, I can't remember his name, but he has this thing called Crash Course, and it's a 10-minute video. He talks really fast, but he's really funny and entertaining, way better than me. But it's a great refresher to watch before or even actually afterwards to kind of see what you took away from slowing things down and learning a little bit. So the nervous system is really important to learn about with manual therapist, as you are having a huge impact on the client's nervous system. The nervous system encompasses all of the nerves, brain, spinal cord that controls and regulates your body and all of the systems of your body, including the organs, all of the glands, your heart rate, everything. It works closely with the endocrine system, and it directs and coordinates the functions of every other system. The nervous system is more quick acting, where the endocrine system is a little bit slower, but both are really important and they work hand in hand. In manual therapy, it's important to understand the impact of your touch, pressure, and movement of the nervous system, and also to avoid irritating major nerves that could be, irritated with a deep tissue massage, or even trigeminal neuralgia, which is actually one of the sensory nerves of the face, which can be severely irritated in what I just said, trigeminal neuralgia. But if you have somebody with TMJ dysfunction, working on a person's jaw might irritate this nerve. So it's important to be aware of where these nerves are and what impact that you have as a manual therapist on it. So with the nervous system, not a lot is known. They do know how action potentials are propagated, how nerve conduction occurs, but they don't understand how this electric energy, electrochemical energy, translates to pictures and thoughts and emotions in somebody's mind. So it's quite a mystery and still pretty magical. Neurologic conditions tend to be a little bit more difficult to treat as well, because we don't know enough about the nervous system to completely alter the dysfunctions that can happen with it. A therapist, knowing about the nervous system, can also do an assessment and make conclusions about where their pain or discomfort or muscle weakness is originating from, and actually alter tissue and help move the nerves in order to solve the pain problem, whether that be a nerve impingement due to a muscle spasm, or some other issue that they're having. It's also important to understand and monitor your own thoughts and feelings, as this energy can actually be translated through your touch on a client. So as far as functional organization goes, nerves are going to be fitting into a couple of categories. They have sensory function, which gives them the ability to detect broad spectrum of stimuli. Stimuli is any change in the internal or external environment that triggers an action potential in that nerve. Don't worry, you'll learn all about action potentials in your next class, but for now we're just talking about how everything's kind of laid out, how it kind of works, what the tissues look like, that kind of thing. So sensory functions, and then we have integrative functions. This is the ability to process what the sensory information means. So at your higher brain centers, whether that be wherever in your central nervous system, your spinal cord could cause a reflex, which there isn't any higher level thinking, but there is still integrative function. It's this embedded mechanism that responds to a stimuli that's like severe sharp or severe hot or severe hurt of some kind, that your brain, you don't have to waste that millisecond transferring that information to your brain to say, ouch, that hurts, take your hand off of it. It happens at the spinal cord level. So it's like a very quick reflex that, oh, I touched a stove off. You don't even have to, you can think about it after you've actually caused the response. Okay, so sometimes you think about the response before you do it, and sometimes you think about the response after you've done it, depending on what level of processing is required. Motor functions are commands from the brain via nerves to activate muscles, glands, and organs. There's two major divisions. We have the central nervous system and the peripheral nervous system. So when I'm talking about the central nervous system, I'm only talking about the brain and the spinal cord. They are continuous. Yes, we say brain and spinal cord, but they work as one. For the sake of studying, we tend to separate them just because it makes it easier to take it apart in bite-sized pieces. But always have that overarching understanding that the central nervous system consists of the brain and the spinal column, and then the spinal nerves that extend off of the spinal cord and the cranial nerves that extend off of the brainstem have a mixed function. So remember how I talked to you about sensory functions and motor functions of the peripheral nervous system. Cranial and spinal nerves have both sensory and motor functions, so they're called mixed nerves. Other kinds of special sensory receptors, such as smell and sight and hearing, are only sensory, but we're not learning about those in any great detail for your time here at Wellington College. So yes, this is just kind of an overview. Now, looking at the anatomy of a neuron. This is a typical neuron. It's a multipolar neuron, and it's multipolar because it has many projections off of its cell body. So a neuron is a cell, and it has different projections off of it, including the dendrites, which are these like shorter, highly branched regions, which will pick up information from different neurons, or could even be like a free nerve ending. They might be attached to some sort of sensory organ, I guess would be the right word, to detect deep pressure, light touch, vibration, all of those things, and convey the information into your central nervous system. So the cell body is just like every other cell. It has a nucleus and all the organelles that make a cell, like a mitochondria, Golgi apparatus, lysosomes, etc., etc. But they also have these like microtubules, which keeps the cell, maintains the cell shape, but it also allows for different movement. So there's like a highway here, where the axon is conveying information that's happened from or been transmitted to the axon hillock here to be propagated down the axon. It's a one-way traffic lane. So you're only getting information sent one direction to the very terminal end called the axon terminal, with these little swellings at the very tip, which are called the synaptic bulb. The synaptic bulb, we learned about this with the muscle system, where remember how you have that synapse where there was a nerve and a muscle and they created a neuromuscular junction and neurotransmitters came out of one end of the axon and into the muscle. Well, this is very similar, except axon to axon has a little bit of a different synapse or coordination there, but very, very similar. So if you have that idea in your head, you're on the right track. We also see myelin sheaths on this axon. This is a myelinated axon. Not all nerves have myelin, but when they do, it actually will speed up nerve conduction. And when somebody has a autoimmune disease that attacks the myelin sheaths on their neurons, this is actually called multiple sclerosis. I think that is all I have to say about the anatomy. There is 3 different structural classifications of yeah, I already talked about that. Oh, I didn't mention this. So nervous tissue is having both neurons. So this is a neuron. This is a impulse conducting cell. Okay. You also have glial cells, which we're going to talk about in just a couple slides, but they are more, they actually translate to glue, but they actually do more than just hold together neurons. They have different functions, and we're going to talk about that. But yeah, for right now, neurons, the dendrites, we talked about it, receiving the stimuli. Cell bodies have all the same things that a regular cell has. And axon carries nerve impulses away from the cell body. It's one direction. Impulse conduction goes from dendrite to cell body to axon. Dendrite, cell body to axon. So a couple of different structural classifications of neurons. There's 3 structural types. We have a multipolar neuron, which is this guy over here, which is the most abundant and most common. You have a bipolar neuron, which has 2 projections coming from the cell body. That's how you remember which one it is, how many projections are coming off the cell body. So here we have multiple. Bipolar, right? We have one going to the dendrites, one going to the terminal ends, synaptic end bulbs. And this is going to be found more in like sensory structures, like in the ear and the eye, that kind of thing. And then you have a unipolar neuron. I think these are found more in young children. I can't recall, but they have just one projection, and then the dendrites and the axon are kind of going in one direction and attached by a little stem. Well, in this case, it's a little bit thicker, but one stem. Yeah. So yeah, like we talked about before, there's the 3 functional types: sensory, motor, and interneurons. Now you'll see PNS and CNS. This is referring to peripheral nervous system and central nervous system. So there are no interneurons in the peripheral nervous system. They are only in the spinal cord and brain, because when interneurons are there, they're creating these connections to have higher level processing, to convey information and connect different parts of your central nervous system. So that, say, if you did pull your hand away from a hot stove, you have that motor control where it tells your hand to pull away as quickly as possible, but then you'll have another interneuron that makes a connection and goes up into the brain to tell the brain what has happened and make sense of it all. So the neuroglial cells, which are the other type of neurological cell besides the neuron, that's found in both the central nervous system and the peripheral nervous system. Their job is to support and protect neurons. In the central nervous system, you're going to have astrocytes, oligodendrocytes, microglial cells, and ependymal cells. Astrocytes look like little stars. They're quite large, and their job is to support and nourish your neurons. They maintain a good chemical environment and also help to form scar tissue when there's neurological damage. Oligodendrocytes are super important because they create myelin in your central nervous system. This is this guy here. Myelin sheaths help speed up conduction. Young children before the age of three or four, most of their nervous system is unmyelinated. So that's why it's really cute watching kids play, because they're clumsy and not as coordinated. They have delayed reactions. So if you throw a ball at them, they have like they get hit in the face and then they kind of go for it, because their nervous system isn't as sophisticated or quick as their parents or older kids around them. And this is also an issue when it comes to like potty training, because the nerve myelination isn't there yet. So they don't have complete control over their external urethral sphincter controlling their flow of urine when their bladder's full. So that's why it can be especially frustrating for parents and children under the age of 3 who are trying to be potty trained. And really, if there's lots of accidents, it's really indicated to not force it, because their neurological system just may not be developed enough yet to actually control their bladder, and can cause a lot of emotional trauma and stress on the family, especially the child. So best to take a break and don't force it, and wait for the nervous system to kind of catch up in its development. And we also have microglial cells. These are the smallest cells of the neuroglial, but they're really important because they're there to engulf bacteria, pathogens, debris, waste products. They kind of clean everything up. And then ependymal cells are here. They're ciliated. They're kind of acting, they're not, but they act like epithelial cells lining the specific structures in the central nervous system that secrete cerebrospinal fluid. In the peripheral nervous system, we have Schwann cells and satellite cells. Schwann cells are important because they help to form and maintain the myelin for the peripheral nerves, neural axons. They are particularly different than the oligodendrocytes by the way that they can regenerate myelin, where the oligodendrocytes are slower at doing this and really inefficient. So when we're talking about something like MS, there's very slow recovery, well, no recovery for it really, because it's a progressive degenerative disease. But because these oligodendrocytes cannot produce more myelin sheath in the central nervous system, there's scars and permanent damage. Whereas in your peripheral nervous system, you can regenerate damaged peripheral nerves because these Schwann cells can reproduce the myelin. Satellite cells, they basically provide the structural support and regulate exchanges between cell bodies and interstitial fluids. So they're just kind of supportive cells. But oligodendrocytes and Schwann cells are ones to kind of compartmentalize together, but knowing that one has an effect on the central nervous system and one has an effect on the peripheral nervous system. They both involve the generation of myelin sheaths, but the oligodendrocytes are not forming new myelin where Schwann cell is. Oh, and here we talked about multiple sclerosis already. So there's some words. We will be talking about it again in pathology. It's a pretty important disorder that affects many individuals, especially in Canada. And yeah, it is an autoimmune disorder that has to do with the impulse conduction problem and can have these alternating acute inflammation and remission episodes. So it's quite frustrating. To treat it, patients will go back and forth between feeling well and not well. Manual therapies are contraindicated during the active cycles, but can be very helpful when it's in remission. Okay, so when we're looking at the anatomy of a nerve, this is what we are seeing. So we have the axon, which has the myelin sheath surrounding it, the myelin created by the Schwann cell. Surrounding an axon is called the endoneurium. Okay. Bundles of axons create nerve fibers and are encased in the perineurium, and this is called a fascicle altogether. Multiple fascicles are bundled together by the epineurium, which is surrounded, each fascicle is surrounded by a layer of fat. Arteries and veins are supplied through this connective tissue and supply the nerve with nourishment and oxygen and waste removal. And that's what makes up a nerve. So it looks very similar to a muscle tissue when we were learning about that. And here we're just talking about different words. It's kind of same organization. You do have to know these terms. So cranial nerves there's 12 pairs of cranial nerves bilaterally, so on right and left side, and they originate from the brain stem. So here we have the brain, we're looking at it from the underside, so it's like we're holding the brain in our hand and we're looking at the spinal cord, which has been severed off the brain stem. And I don't need you to know the locations that these nerves stem from, but you can kind of why they're named after Roman numerals. You do have to know their name by their specific name and their Roman numeral. Okay, so it does take some memorization. There is some mnemonics out there that can help you with it. I always come across, or I learned a dirty one, and I don't even remember it. Well, maybe I can, but I'm not going to repeat it on here. You guys can come up with your own or Google one, whatever you like. And yeah, so you have your olfactory. I always remember this. You have one nose, and it's your number one cranial nerve. You have two eyes, and so it's cranial nerve number 2. 3, 4, and 6 have to do with the movements of the eyes, ocular motor, trochlear, and abducens. Number 5 is your trigeminal nerve. That one has sensory and motor function in the face. That's why they're showing you 2, because cranial nerves typically only have sensory function, but trigeminal is unique because it has both sensory and motor function. I guess that's not exactly true. What they're showing here is their dots are showing you that it's motor function, and the solid lines showing that it's sensory. Okay, so far, this is our first sensory and motor nerve in one cranial nerve. You have the glossopharyngeal, which is affecting the soft palate and the pharynx. The vagus nerve, which becomes very important in massage therapy because it actually has a connection from the brain to the organs, which is kind of your portal or your highway to relaxation. The accessory nerve, which is controlling the sternocleidoid muscle, and your hypoglossal, which is controlling motor function of the tongue. The vestibulocochlear is having to do with balance, and your facial nerve is controlling motor function of the face, and even some sensory function. So a little bit of a pathology alert, even though we will be talking about pathology in more detail. But the paralysis of facial muscles, Bell's palsy, this is quite a common condition. I've had it twice. It's some sort of inflammation or damage to the cranial nerve. So here we have a cranial nerve 7, facial nerve, cranial nerve 7. And when a nerve is inflamed, it swells just like everything else, and you can see that it's passing through a foramen here. And that causes a little bit of an impingement of the nerve, and anything downstream from that impingement is going to be altered. So both motor function and sensory function will be altered here. Signs and symptoms, oh, they think it's mostly caused by a viral infection. Viruses, certain viruses tend to be latent, meaning that they don't get completely resolved by the immune system, and instead they evade the immune system. They stay in their host and take a home in a nerve root. And then when that individual is depleted in some way, whether they're stressed out, they don't have enough sleep, or their immune system is just depleted in whatever way, then the virus can come back out and cause a reinfection and can affect the facial nerve. You'll also hear about this in shingles and pathology. It's a different viral cause, different nerve roots that are affected. Those are the intercostal nerves, but same idea. Viruses have this tendency. But don't worry if you didn't catch what I said. We will be talking about this again and again in pathology. Signs and symptoms occur of weakness or drooping muscles on one side. So I literally woke up and had one side of my face drooping, like I couldn't work it. I couldn't blink one eye. I couldn't smile on one side of my face. Thought I had a stroke. Luckily I didn't. I went to the hospital and they treated me. I'm not sure if I told you this story, but I'm going to say it again because it highlights the power of what therapies that you have access to. So I had it twice, like I mentioned. The very first time I had Bell's palsy, I thought I had a stroke because I didn't know about Bell's palsy, but they gave me an antiviral and a steroid, right? So that antiviral to take care of the infection and a steroid to suppress the inflammation and have that nerve swelling go down so that the nerve can actually get restored. The first time I had it, I had loss of function, the face drooping and weakness on my right side of my face for 3 months. And it's kind of embarrassing, right? Because everybody's like, what's going on with your face? And you feel weird and you actually can't taste on one side of your tongue. I continuously bit my tongue because some of the control of my tongue was off and sensation of it. And so not comfortable at all, and including, just like some of the muscles. And it's kind of interesting as well, because you'll see there's many, many branches off this facial nerve. One problem with Bell's palsy is that it feeds innervation, like the impulse to the lacrimal gland, which creates tears. So when that's not innervated, the eye can get kind of dry. So often people with Bell's palsy will have to wear eye patches to like force their eye closed. I didn't have to, or they'll sometimes give you drops. And it also innervates the salivary glands. So I don't know. A surgeon said that this might be right because this can happen, but I swear that this is what's happened to me, because when I had Bell's palsy, I had, no tears and less saliva. And then when my nerve was regenerated, I started tearing up when I would eat. Like when I should be salivating, I would tear up. I still do, especially if it's a rich carbohydrate meal. So anyways, it kind of interesting. And then the second time I had Bell's palsy, I knew what it was this time. I still got the standard of care. I got the antiviral medication and the anti-inflammatory steroid. But this time I applied contrast alternating hot and cold towels on my face, like a wet, hot, wet, and then a cold, wet, like in the 3-to-1 ratio, just like you've been taught. And I thought, why not? It was the middle of I was in the middle of nowhere. It was winter around the holidays, so I couldn't get in. Acupuncture is really successful in treating Bell's palsy as well. But so what I did was I did this alternating treatment a few times a day, and I noticed there was fasciculations and like movement within my face. And I thought, well, this is interesting. So I continued to do it. And 6 days later, I had function back in my face. When you compare that to 3 months, that's quite good, and something that you may want to offer your clients with Bell's palsy as well. Just saying. But you want to avoid deep or vigorous manipulation of the tissue. You want to continue the circulation, which is what that alternating hot and cold was doing, and tissue flexibility, but yeah, be gentle. It doesn't hurt, but you do have like increased hearing sensation. So when people get close to you and yell, it's really, really loud. So other spinal nerves. So the nerves can either be cranial nerves or spinal nerves. Okay, so we've talked about the nerves coming from the brainstem. Now we're talking about the nerves coming off the spinal cord. They're named and numbered according to the location of the spinal column or whatever vertebral body they are at. There's 31 pairs of spinal nerves, and they're named for the segment above them. So like, for example, at your T1 vertebral body, the intercostal nerve below it is called T1. There's and same with the lumbar and the sacral, but there's something funky about the cervical naming. And it's just because C1 comes out above the C1 vertebral body and below the occipital bone. So for this reason, they're named for the one above it. The nerve is named for the vertebral body below it. Oh gosh, did I screw that up? Right, so in the thoracic spine, you have your T1 vertebral body, the spine, the spinal nerve below it's called T1. In the cervical spine, you have C1, the nerve above it is called C1. You have C2, the nerve above it is called C2. Until you get to C7, okay, so C7, the one above it is C7, but then you get to T1 and you have this nerve up here, right? What is it called? Is it called a T1? No, the one below it's called T1. So they have this extra C8 nerve. You just have to remember that, okay? Like, it's just the way it is, which can make it a little confusing. And if you need me to repeat that, I definitely will. It's also in your textbook. You can read it. On page 173. It'll verify that for you. Okay, so spinal nerves will also converge to form common networks that innervate body regions, and these are called plexuses. They are highly branched nervous networks. You have the cervical, brachial, lumbar, and sacral plexuses. The cervical and the sacral plexus seem to be more of a clinical, the brachial and the sacral plexuses are more of a clinical, of clinical interest, but we're going to go through all of them. So we're going to talk about in pathology in more detail what can happen with impingement of these different plexuses, but at the cervical plexus, It's innervating the head, neck, and face. And something to kind of bring attention to, yeah, I didn't mention it here, so it's going to be in your pathology, is that in your cervical plexus, you're going to have branches from your C3, C4, and C5, which innervate the diaphragm. I really should have connected this here. Diaphragm, which becomes important because if somebody has a cervical spine injury, that can affect their ability to breathe on their own. So depending on the level of their injury, can actually cause paralysis of their diaphragm. Brachial plexuses are innervating the upper extremity and are super important when we're talking about different numbness and tingling or weakness in the hands. Lots of different pathologies can originate here. There's different nerves that are formed due to these branches, which is the axillary nerve, the musculocutaneous nerve, the radial nerve, median nerve, and ulnar nerve. So there's 5 important nerves that come off the brachial plexus that extend all the way down the arm. In your lumbar plexus, you're giving rise to nerves such as the femoral nerve, which is innervating the quadriceps, and the obturator nerve, which is innervating the medial thigh and the genitals. The sacral plexus is of interest because it has branches off L4, L5, S1 to S4, and gather together to form the largest nerve of our body called the sciatic nerve. Sciatic nerve, sciatic pain, sciatica, whatever you want to call it, is a really big complaint and reason why a individual may seek care with a massage therapist. There's really 2 ways that sciatic irritation can occur, and one of them is due to the piriformis syndrome, which is the piriformis muscle is tight, which overlaps the sciatic nerve, causing compression, and then you'll have that nerve irritation. Same thing like I told you about with the Bell's palsy. You have compression of a nerve, you're going to have some dysfunction, including weakness or numbness. And so that compression of the piriformis muscle, we're just pretending that the piriformis muscle is here because it's just not in this picture. You would relieve the tension of the piriformis muscle, and therefore you're taking the compression off of the sciatic nerve and restoring its function. You can also have like a disc herniation or nerve impingement at the spinal root, which is just adjacent to the spinal cord. And that can also cause sciatic irritation without any piriformis involvement. So when you know what the root cause is of your sciatica, you're better able to treat it. And that might be a co-management case with a chiropractor or a physiotherapist, as well as massage therapist, because whenever you have dysfunction of the body, whether that's nerve related or joint related, you're going to have muscle spasms in that region as well. All right, so that is all I wanted to talk about today. Next class, we're going to be talking about impulse conduction and action potentials. I think that's probably one of the more challenging topics that we'll be talking about. But for now, we'll just kind of review what we just talked about. So we talked about the nervous system as a major regulatory system and something that works alongside the endocrine system, and important for a manual therapist to be familiar with how their touch impacts a client's nervous system and how to avoid irritating or aggravating inflamed or aggravated nerves. There's a functional organization, including sensory, integrative, and motor functions, and 2 major divisions, including the central nervous system and the peripheral nervous system. We talked about cranial nerves and spinal nerves today, which are part of the peripheral nervous system and contained mixed sensory and motor axons. We talked about the structure of a neuron and how a neuron has dendrites, terminal ends with synaptic end bulbs, and cell bodies, just like every other cell containing a nucleus and all the other organelles. We talked about an axon and myelin sheaths. We talked about different structural types of neurons, including a multipolar neuron, a bipolar neuron, and a unipolar neuron, multineurons being the most abundant and common. We talked about how interneurons are only found in the central nervous system for higher level understanding, discerning, decision-making, etc., etc. We talked about neuroglial, which are the glue of the nervous system, consisting of central nervous system glial cells and peripheral nervous system glial cells. The astrocytes support and nourish the neurons. Oligodendrocytes form the myelin sheaths of the central nervous system. Microglial cells act with the immune system and act as microphages to clean up any debris and make sure that there's no infection within the central nervous system. And the epidermal cells, which secrete cerebral spinal fluid. Schwann cells are analogous to the oligodendrocytes, which form myelin sheaths in the peripheral nervous system, which can regenerate myelin, where the oligodendrocytes cannot. We talked a little bit about multiple sclerosis, and we talked about the structure of a nerve. It's important to remember that a bundle of nerves makes up a fascicle, which is covered by the perineurium. Axons are covered by the endoneurium, and a bundle of fascicles is covered by an epineurium, which creates a nerve. We talked about 12 pairs of cranial nerves and how they have sensory and motor control, depending where they're at. And you know, what I kind of expect from you is I do expect you to memorize their names, their Roman numerals, and kind of what they do. And I know that's a huge feat, so it takes a lot of just, you know, your own personal study time, but there is a table on table 7.1 in your textbook that outlines it there. Have a read over it a few times and get comfortable with that. You won't be learning how to test all cranial nerves, but certain cranial nerves are important, especially the vagus nerve in massage therapy, and the accessory nerve. We talked a little bit about Bell's palsy and how nerve conduction is impaired when there is some sort of nerve compression. Then we talked about spinal nerves, which stem off of the spinal cord. There's 31 pairs, and the cervical spine has a little bit of a funky C8 nerve that doesn't correspond with its normal naming and numbering according to the location of the spinal column. You just have to remember that C8 is in between the vertebral bodies of C7 and T1. We talked about the 4 major plexuses: cervical, brachial, lumbar, and sacral, and how the cervical plexus innervates the diaphragm. So cervical spinal injuries can cause a problem with breathing, someone breathing on their own. And we also talked about how the sacral plexus gives rise to the sciatic nerve, which can cause major pain down the back of the leg and the buttocks. There's our pictures of our plexus, and that is it for me today. Check out your workbooks from your outline. I think it's page 96 to 103. I can't remember. Check your outlines, do your workbook. I think it'll be really helpful, and practice learning your cranial nerves. All right, I will see you soon, and take care for now. Bye.